Hi everyone, welcome to Real Talk Med School. In this episode, I'll give you a sneak peek into a day in the life on internal medicine rotation, and then I'll dive into how to give a solid oral presentation. Giving a good oral presentation is super important on this rotation because most of your interactions with the attending happens during rounds, and that's your time to shine for your evals. You'll spend the rest of your time with residents, which will also play a role into your evaluations, but standing out to your attending is especially important if you're thinking about going into internal medicine. So I hope that this is helpful. I get up at 6:30 a.m., shower, pack my lunch, and get ready for the day. Quick fit check before I leave. I'm off to the hospital at 7:30 to then make it there by 7:45. I pre-round on my patients, and rounds go from 8 a.m. to 12 p.m. and are sometimes followed by didactics at 1 p.m. Then I like to head over to the gym for a workout and finally finish my day by doing UWorld questions. So I very quickly want to break down oral presentations to you guys just because this is something that I struggled with. The advice that I was given was that our attendings would kind of let us know their style, but in reality, everybody has a basic format that you should be following, and then the attending will let you know what changes need to be made from their standpoint. But in general, there are three different types of oral presentations, and this all depends on your physician. So what I mean by that is if a physician does not know the patient and the patient is being newly admitted to the medicine team, then what you're going to do is give an oral presentation on that patient in HPI format. So you're basically going to begin with the chief complaint. You are going to state why the patient came in, the issues that have been occurring previously, and then what exactly happened that made them think to themselves, I need to get to the hospital. Then you're going to also give a short ROS, and you're going to say that the patient endorses ABC but denies XYZ. Then you're going to get into past medical history, and this should include medical conditions, medications that they are taking, any recent hospitalizations, recent surgeries, allergies, etc. Then you're going to give pertinent family history, and it's important that it is pertinent, right, for the presentation of the patient. For example, I don't think your attending is going to care if a patient has a family history of gout, if they're coming in with a cardiac issue, but it's important to note that a patient's maybe mom or dad had a heart attack. And then social history as well will follow that same format, only pertinent information there too. But it's important, this is also where it's important to get to know your patient a little bit better on a human level, because social history is very important for discharge notes. So it's important to know that the patient will be able to be safely discharged afterwards. And so it's important to kind of get a gist of their living situation as well. And then from there, you're gonna go on to the physical exam. So this is gonna be like your vitals. Always want to assess the patient in general, do a heart and lung exam, and then anything else you feel may be important. But those three you should always be doing. And then you're going to talk about their labs if you have that already. And so for their labs, you should be presenting it in a fishbone diagram. I don't know the official name for this, but it should look somewhat like this. For this type of diagram, so what you have is your CBC, and there is the white blood cell count, the hemoglobin. We also have the hematocrit, but a resident once told me that the hematocrit is really just the hemoglobin times 3. So sometimes it's okay to leave it out, unless you think it may be important. And then also the platelets as well. And then you go on to your CMP, and that's going to include your sodium, your potassium levels, chloride, bicarb, BUN, creatinine, and then also glucose. And then after we give the CBC, CMP, and anything else that may be relevant, and that could include, like, let's say an A1C, right? So if a patient's coming in and their glucose levels are really high, maybe you also want to talk about the A1C. Or if their BUN and creatinine is out of range too, then maybe you want to talk about their EGFR. and etc. Then you want to go into some imaging that may have been done or that is pending for the patient. And then you also want to give your assessment. And then you want to think about some differentials. So my school personally uses Vindicate, but I feel like when you need to kind of think of differentials on the spot, maybe you should categorize them differently. So the way that I do it is I do it in 3 different types of differentials, from most life-threatening to a probable differential to the most likely. So that then when I'm presenting and I give my assessment, I can say, for example, I don't know, like Jackie Robinson is a 35-year-old male coming for ABC, XYZ on physical exam. He had blah, 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 and thereby making the top differential this. However, we should also consider this, right? Like maybe I might give my the most life-threatening differential, and then I could say, so it's important that we investigate it using that, whatever it may be, like it could be like a CT scan or something. And then I'll also give another probable differential too, and I could say something like, you know, he's on this certain type of medication, so maybe there's like a drug to drug interaction somewhere there. So that's just something to think about. They really like it when you give multiple differentials and also explain your reasoning why this could be it, and also explaining your reasoning why it probably won't be that. And then you want to go into your plan. And when you're thinking about a plan, it's best to also go over it with your resident that's on the team before presenting this to the attending, just to make sure that it makes sense, right? That's something that I also struggled with too. So it's important to kind of go over that with your resident to make sure that it makes sense and that it's a good plan, and then you can present that to your attending. So then the second type of oral presentation that you're going to give is for the following day, right? So the attending knows this patient and now they've been admitted to the medicine team. Now the following day, we have to give another oral presentation. And so the way that we're going to do that is with the SOAP format. In the SOAP format, the S stands for subjective. So first you're going to include any overnight events that may have happened. And then also go and see your patient before presenting this, so that you can say the patient feels well today, or the patient doesn't feel good today, was complaining of cramps overnight, something like that. Then you want to talk about your objective data, so that's going to be your vitals and then your physical exam. Really important that if you're using Epic, that you go onto summary and then you go to vitals graph, and then you can see any type of fluctuations that may have happened in the vitals overnight. For example, I had a patient who he kept on having spiked blood pressures, but only at the nighttime. So even though his blood pressure was normal in the morning time, it was really important that I noted that his systolic blood pressures were pretty high overnight. So I would say something like, so for his vitals overnight, his blood pressures ranged, systolic blood pressure ranged from 160s to 190s over 80s to 90s, like something like that, so that they can get a range. And then that's also really important for temperature as well, because patients can have fevers overnight and then be able to break them in the morning. Then you're gonna go on to your labs and your imaging as well. And I really like to use a multicolored pen like this, because as I'm giving my oral presentation, I want to remember which lab values I want to emphasize to my attending. So I'm able to use the red if I want to emphasize that something is out of range or abnormal about these labs. And then I'll use the green if I want to say like, oh, this lab value's like improving, right? So let's say a patient had come in hemorrhaging, and then we had to give a blood transfusion. They were admitted with a hemoglobin of 5, but now today, after the blood transfusion, their hemoglobin's at a 7, right? So I'll then use my multicolored pen to go to green, and then I will circle it like this, so that I can remember like, oh, okay, the hemoglobin is still low at a 7, yes, but that's an improvement from the 5 that it was. So basically it's just like a memory thing for me to put it in green, that like even though it's a low out of range value, it's not technically red because of the fact that we wanted to see that improvement. And for that example of like hemoglobin being low, then you also want to give the MCV and the MCHC and things like that, so that you can give more of a picture as to what's going on with the patient. Also make sure to interpret these, right? So you can say, so their labs today showed a high white count, that can be indicative, and also they had a high temperature, that can be indicative of an infection. And then you can go more into that in the plan. Then you're going to talk about any imaging that may be there, and then you're going to give your assessment, and then you're going to give your plan. And the plan, most of that will really come from the notes, so make sure to also read your notes before giving an oral presentation, because for example, if a patient did come in with a heart attack, then cardiology is most likely going to be dropping a note every single day. So you want to make sure that you're on top of those to see exactly what they have planned for this patient. And then, as always, like I stated before, also go over that plan with your resident. And then finally, the last type of oral presentation is when the patient is still admitted to medicine, but the attendings change. So for example, at the hospital that I was rotating at, the attendings changed every single Wednesday. So if a patient was admitted on, let's say, Monday and was there also on Wednesday as well, and they have a new attending on the team, the attending doesn't really know the patient that well. So you're going to give a great one-liner here. So you're not going to give an entire HPI for this patient, but you're going to give SOAP format. You're also going to give a one-liner that includes the hospital course. So for somebody who's coming in for, let's say, sepsis, then you're gonna say this patient was admitted 4 days ago with, like, I don't know, signs of like peritonitis, became septic. Then you can say, like, we gave this antibiotic for this patient and we did X, Y, and Z. And so just kind of keep getting them up to speed as to what occurred in the hospital for this patient. And then you're going to continue on with the SOAP format from there. So that's really it. Those are the 3 types of oral presentations that you're going to be giving your attending based on how well they know the patient, pretty much. And so now for an example, I'm going to give you an example of an HPI, and this is with the fake patient. This is not a real patient at all. Lisa Simpson is a 34-year-old female admitted to the medicine team with the chief complaint of lower pelvic pain that began 3 days ago. She describes the pain as a dull ache in the suprapubic area that occasionally radiates to her lower back. The pain is constant but worsens with movement and urination. The past medical history of endometriosis diagnosed via laparoscopy in 2021. She reports that the pain is similar to prior episodes but more intense. She is sexually active and uses condoms inconsistently. Denies any abnormal vaginal bleeding, but notes increased vaginal discharge over the past 2 days. She has not experienced this level of discomfort since her last flare-up, which occurred over a year ago. So she denies fever or chills, chest pain or palpitations, shortness of breath or cough, nausea, vomiting, or changes in her bowel habits. She does report pelvic pain and increased vaginal discharge. And then I would talk about the past medical history again, and I would say, so her past medical conditions include endometriosis, diagnosed in 2021. For medications, she uses ibuprofen as needed for pelvic pain. Her family history is significant for her mother having uterine fibroids. And then I would talk about any type of pertinent social history as well. So I can say she reports occasional alcohol use, approximately 1 to 2 drinks on the weekends, and denies tobacco or recreational drug use. She is currently sexually active with 2 male partners and uses condoms inconsistently. And then you can go on to your physical exam. So you can say for her vitals, so this is like where like the doctor's style really comes in, right? Because Some attendings don't mind if you say, for a patient's vitals, she's afebrile and the rest of her vital signs are normal, and then just keep it pushing. But for some people, they want all the numbers, right? So that's really like, they'll stop you and then they'll tell you, they'll say, you'll start with like blood pressure, and then they'll say like, if everything's normal, then just tell me that it's normal, and then you can continue. And that's the same with labs as well. So then for physical exam, so I'm just going to read it out. So blood pressure is 124/78, temperature is 99.1, pulse is 84, and she's satting at 99% on room air. So it's important to note if the patient is breathing without any like support, right? So if they're breathing on room air, then say that. But if they're breathing with a nasal cannula, then make sure to note the liters of nasal cannula. So some people could be on 2 liters or 3 liters, etc. So in general, the patient appears uncomfortable but in no acute distress. Like I said, always include heart and lungs. So you're going to say for her heart, normal rate and rhythm, no murmurs appreciated, lungs clear to auscultation bilaterally, no wheezes, rales, or rhonchi heard. Then for abdomen, mild tenderness in the suprapubic region, no rebound or guarding. We also did a pelvic exam, and so cervical motion tenderness was noted, no adnexal masses palpated, and she had moderate clear discharge present. And then for labs, like I said, you could say like all labs were normal, or except for this and that, or they'll make you read out all of the numbers, but make sure to do it in the fishbone format, and also add in any other lab values that may be important. So for her, the urine pregnancy test was negative, STI panel sent and pending, and pelvic ultrasound results are also pending as well. So for assessment, Lisa Simpson is a 34-year-old female with a past medical history of endometriosis who was admitted to the medicine team with the chief complaint of pelvic pain and increased vaginal discharge. Physical exam reveals suprapubic tenderness and cervical motion tenderness. Top differential at this time includes pelvic inflammatory disease given her symptoms and history of unprotected sex. So it was important that you kind of give the big picture as to why the patient is here, any type of like pertinent, like really important information that led us to the differential without being repetitive of what we just said before. And also, like I said, so I gave the most likely differential, but I can also say, however, given her history of endometriosis flare remains on the differential, although the discharge and acute tenderness raises concern for infection. And then I'm going to go on to my plan. For this patient, we could start with antibiotics and then try to like use like a resource like AMBOSS to look up what type of antibiotics we should give Ms. Simpson. And then pelvic ultrasound, we did that, so that's pending. So we'll wait for the results. And then we'll also review the STI panel results when available and adjust treatment if necessary. So that's the way that I would give the HPI for this patient. And if they were just newly admitted to the medicine team, most likely this type of patient wouldn't be. If they were presenting to the ED with the symptoms that I just said, most likely they would just be given antibiotics and then sent home. But maybe this patient would have been admitted, who knows. And then for the next day, if they were still there the next day, the way that you would give the oral presentation would be in a SOAP format. And let's say then they're there for the next day, but physician A switched over with physician B. So now physician B does not know the patient. Now you're going to give your presentation in a SOAP format, but you're going to also give a great one-liner too and explain Lisa Simpson's hospital course, what we've done for her, etc. So I hope that this is helpful for you. I still need a lot of practice in this area as well, but we're in clerkships right now, so this is the whole point. We're supposed to be practicing doctors, not doctors just yet. So give yourself some grace when attempting to give oral presentations.